ومن أحسن قولا ممن دعا إلى الله وعمل صالحا وقال إنني من المسلمين.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Nimr Ikram. I'm an orthopedic surgeon. Been in practice for about 20 years. Moved to Dallas about 8 years ago. And a lot of times people will come up to me and kind of say, "Oh, doc, my knee hurts, my shoulder hurts, my hip hurts. I feel some grinding, some swelling. What's going on?" And of course, one of the most common things that we see is arthritis. So today, I'm going to kind of give a quick overview. Obviously, arthritis is a huge topic, but inshallah, I'll give a quick overview about what we know about arthritis and how we can treat it, and inshallah, we'll go from there. So what is osteoarthritis? So arthritis is a chronic degenerative disease causing a gradual loss of the articular cartilage. So people ask, what is articular cartilage? So when you talk about a joint, you have more than one bone, be 2, 3, or 4 bones, that allows movement. So again, when you're talking about the finger, you have the little joint right here. So both ends of it have, the bone is covered with cartilage. So things move smoothly. So what arthritis is that you're going to have a gradual loss of that articular cartilage. And there's 4 stages of arthritis. The first is when it's still smooth, but it's soft. The second is where you start getting some wear in there. I kind of call it like peach fuzz on there, so it's not smooth anymore, and it starts getting kind of fibrillations, what we call there. The third is when you have a crack down to the bone, and the fourth is where bare bone's exposed. So this really is the most prevalent disease in our society. It really affects the women it's the 4th most common impact of women and the 8th most common disease on men. 10 to 15% of everyone over 60 years of age will have some degree of osteoarthritis, and this leads to over 100,000 hip and knee replacements just in the United States alone. So it is a very common thing that we see, and it is very debilitating for people as well. So here in the picture here, we show here, this is the knee joint, this little area up top here. This is the articular cartilage, nice and smooth, nice and white, so that's normal. Down here, again, you see the same thing, that you have nice, smooth, white cartilage. That's what's normal. On the right side here, you see here you have these craters in the cartilage. Again, this is like the worst stage where you're down to bare bone. Some areas up top here where the bare bone is exposed. So again, that is what we're looking at, and that's when you look at a picture, you can see why you feel the grinding as you move it, because it's not nice and smooth like it is on the left side there. So what are the causes? So there are primary causes of arthritis and there's secondary causes. Primary is genetics. Unfortunately, some of us had bad genes. And again, a lot of us will say, "Oh yeah, my mother had a knee replacement, my father had a knee replacement. Oh yeah, my grandparents, they had difficulty walking even at a young age." Oftentimes this can be localized just in one joint, or it can be generalized throughout the body. Oftentimes, women who are postmenopausal, they will have a generalized arthritis. Secondary osteoarthritis is usually from trauma. So again, if you fall, you're going to injure the cartilage there. People who are athletes, again, when you're playing football, again, you're putting a lot of wear and tear on those joints, so that's traumatic. If you dislocate a joint, again, that can cause trauma to the cartilage, leading to arthritis. The next one is obesity. From our standpoint, when you talk about any kind of weight-bearing joint, be that your ankle, your knee, your hip, again, obesity will cause you to put more wear and tear on those joints. You can think about your feet as well. And so again, when you're obese or when you're overweight, that's going to put more pressure through those joints, causing more pain and discomfort. Studies show that if you lose 1 pound of weight, it's like taking 4 pounds of pressure off your knee. So if you lose 5 pounds of weight, it's like taking 20 pounds of pressure off the knees. If you lose 25 pounds, it's like taking 100 pounds of pressure off the knee. So again, that's one of the reasons that we talk about, exercise and losing weight is good for people with arthritis. And then the last one is something that's called inflammatory arthropathy or inflammatory arthritis. People who have lupus or rheumatoid or psoriasis, these are inflammatory processes throughout the whole body that affects the joint and can cause arthritis there. So what are the clinical features? Again, from our standpoint, like I said, oftentimes people will say, I have pain and stiffness. It's usually worsened with some kind of activity, and it's improved with rest. You're going to get joint tenderness and crepitance, which is like grinding when you move joints. So that's what we call crepitance with movement. You'll have some swelling of the joints and effusion, and you have what's called osteophytes. So here in this picture, the left side of the picture here shows a normal joint, while the right side shows an arthritic joint. And again, the reason that I kind of show some of these things is that some of the treatments deal with portion of these areas. So here is the white normal cartilage on the nice and smooth. On the right side, you can see these little craters, what we call the fibrillations. That's where the cartilage has been worn and torn. You have the joint capsule, which is on the outside here. And again, that will get thickened in some patients. Here on the left side, you see a good space here, and you're losing some of the space there. So when you lose the space, the ligaments actually get lax, get loose, and so your body tries to tighten that up either by making the capsule larger or forming these spurs, which we call osteophytes, to try to tighten up that capsule. You also have the synovial membrane inside here, and again, that's important because that gives nutrients to the joint and helps repair it. And then you have the joint cavity, which is the actual area inside the joint, which has the fluid and the space. So pathogenesis, how it happens. So again, as we said, it's a progressive degenerative disease, which is characterized by an adaptive response of the synovial joint that we said, that I showed on the last picture, to a variety of environmental, genetic, and biomechanical stresses, which we kind of discussed already. Cartilage is made up of water and collagen with proteoglycans and glycoaminoglycans produced by chondrocytes. So I know I'm using a lot of big words here, but some of the reason is because, again, when we talk about some of the treatments, we're going to hit some of these words, and that's what we discuss with some of the treatments of putting in fixing the cartilage, putting in the glycoaminoglycans, using hyaluronic acid, things of that sort. So the proteoglycans bind to hyaluronate, which stabilize the molecule, and the chondrocytes receive nutrition from the synovium by circulation of the joint movement. So again, it's thought that if the joint stops moving, the chondrocytes lose their nutrition and go into shock and stop the cell repair. So that's why it's important to do exercise to get movement of these joints, even for people who are arthritic. So what are your risk factors? Obviously, age is a big one. As we talked about earlier, people who are older naturally get arthritis. And so the normal aging causes a laxity of some of the joint, which again causes the osteophyte formation. 27% of people between the ages of 63 and 70 have x-ray evidence of arthritis, and it increases to 44% of people over the age of 80. Obviously, we talked about the trauma. Again, when you talk about the knee, there are the cruciate ligaments. You have athletes tearing their anterior cruciate ligament. You have the collateral ligaments, the meniscus, which is a little shock absorber between the knee. Any of those will cause wear and tear inside the joint, which will lead to arthritis. And then, of course, if you have a fracture is a break. And again, if you break the cartilage, again, that's going to lead to arthritis as well. And so it's 5 to 6 times more likely in men with injuries that they found out that they will get arthritis. And in occupations, again, people who have a sedentary lifestyle, again, they are less likely to get arthritis than those people who are heavy laborers. Again, people who are going up and down stairs, people who are here in Texas, we talk about, the AC units always going out. So people who are doing HVAC and on their knees and going into small spaces, again, they're putting more stress on their joints, and therefore they have a higher chance of getting arthritis. Exercise, like I said, exercise is good for you, but again, if you're an elite athlete, those people who are playing football all the time, they're damaging their joints, be it their hips, their knee, their ankles, their shoulders, their hands. I'm sure we have some pro athletes here in the Dallas area, and again, looking at their hands, they've had multiple dislocation of fingers and things like that, sort of leading to arthritis of the hand. So a lot of these elite athletes and even the weekend warriors, they get sprains, they have injuries to their joints, which will lead to arthritis. Gender and ethnicity, of course, if you're under 50 years of age, men are more common to get it. Over 50 years of age, women are more common. Again, we talked about people who are postmenopausal, in women having a generalized arthritis. So that's why people over age 50, usually women are more common to have the arthritis than men. Obesity, we talked about that. And again, this is the strongest modifiable risk factor. So what does that mean? That means that is the one thing that we can control, that we can modify and make better for ourselves. So that's why it's important to eat properly and to lose weight. Again, as we said, for every 1 pound of weight you lose, it's like taking 4 pounds of pressure off the lower joints. Diet, again, that will help with losing the weight, but also it is found in a study that people who are low in vitamin C and vitamin D have a 3-fold risk of getting osteoarthritis. So it's important to get your vitamin C. There are a lot of people now who are realizing the importance of vitamin D and how a lot of people have low vitamin D. So that's something that should be checked. That's something that should that can easily be brought up by taking supplements. And alhamdulillah, here in Dallas, again, being out in the sun, again, that will help produce vitamin D as well. So the progression, if we look here on the screen, you have different x-rays. So this is your normal knee here on the left side. Again, good space between the bones. Everything looks good. Here, as we progress, all of a sudden you start losing some of the joint space here. You have a little what we call osteophyte here. As you progress here, you're losing more of the space. You're getting more whiteness, which we call sclerosis. That means the bones are rubbing closer together, and you're getting more spurs. And then on the last one, you see, again, that you lost the total joint space between the two bones there. They're rubbing up against each other. You see these large osteophytes that we talked about, the spurs there, trying to make that the ligament tighter to help stabilize the knee. You also see some cysts underneath here. So again, this is the worst. Again, though, it's a slow process. Again, it's not like you're going to get arthritis overnight. And it's interesting, we don't know why arthritis causes pain. So we'll have some people who have this last x-ray where they're bone on bone and they look terrible, but they have no pain. And we have some people who have the first x-ray and they come in excruciating pain. So we don't know why arthritis causes pain. So oftentimes people will come to the office and say, hey, I fell, I injured myself, and I look at the x-ray and I said, you have some terrible arthritis. And they said, yeah, but before this fall, I wasn't having any problems. So from our standpoint, usually you have some kind of initiating event that will kind of stir up the bee's nest inside there, that will get it inflamed and irritated. And once it becomes irritated, then it's our job to try to calm it down and try to make the pain better. So the management and clinical practice. So again, as you come to the office, what do you expect? So from our standpoint, we do patient education. We want to control your pain for you. We want to improve the function, and we want to alter the disease process. So again, what can we do initially? So again, we want to try to do everything conservatively and easily for the patient. So the different non-drug therapies, obviously we talked about, is exercise. It's the single most important intervention that you can do. Twofold. Again, losing the weight will help with the mobility of the joints, stabilize the joints, and make it feel better. The synovium will get moving and will help repair of the cartilage. And then, so when you talk about exercise, though, people will come in and say, oh, I walk and it hurts and I can't do this. So usually you want to try to do exercises that don't put a lot of pressure on the joints. So usually we say if you can do water therapy, if you can walk in a pool, if you can get to a physical therapy place that has water therapy, that'll be better because you can do the exercise without putting the continuous stress through the joints. The other thing too is if you're talking about exercise that you want to do, if you can't get into the water, usually we'll say doing bicycle, because again, the bike you're doing the exercises, but you're not putting weight through the bones as you do that. If you're talking about your shoulder or your arms, there is a hand bicycle that you can do to help that as well. And then if you don't have a bicycle, then we talk about elliptical, and then the last thing is walking. Again, just trying to be active and try to get moved is the best thing. As much weight as you can take off of the joints as you're doing it would be better for you. Next is the weight loss. We already discussed that. And then mechanical aids. So there have been studies that have shown that when you walk, again, if you look at your shoes, most people will have some kind of wear to their shoes, either to the inside or the outside. So no one walks perfectly straight. And again, that's the way we're supposed to walk. So if you look at the shoes, you can see the wear pattern on your shoes, either on the inside or the outside. So oftentimes people talk about shock absorbing footwear. So again, you can put arch supports, or you can put little orthotics into the shoes to help stabilize it, and that will help take some of the pressure off of especially the lower extremities, which are the most common, the knees and the hips that you're going to have arthritis in. So again, that will help take some of the load off of those joints and take some of the pressure off that and make it easier on you. Braces can stabilize the joint. Again, there's braces for all areas, your back, your knee, your wrist, your elbows. For me, I tell people that braces are good, but not long-term wise. I don't want people wearing braces 24 hours a day because that will take over the muscles. And again, then the muscles will get weaker. So my idea is that, again, the braces are, if you're doing exercise, if you're going to be up for a long time, if you're going to be doing some activity that you know that you're going to aggravate the joint, then you can use a brace. But we prefer for you to do exercise to strengthen up those muscles naturally so you don't need the braces. And there is something that's called an unloader brace on the knee. So again, if you're putting all the pressure on the inside, it opens up that joint so that you're not putting the pressure on the inside, and it unloads that area of the joint. So now, what medications can we give to help with this? I mean, worldwide, the first line therapy is Tylenol, acetaminophen. You can take up to 1 gram 4 times a day, so that would be 4 grams a day. Again, that is allowable, but again, you do have to monitor it, because if you take too much Tylenol, it can affect your liver, so you want to be careful about how much Tylenol you take. But that is the first line medication. What we need to realize is that it doesn't help swelling. It's not an anti-inflammatory. So it may help with some of the pain, but if you have swollen joints, that may not help with the pain that you're getting from that. So the second line is an anti-inflammatory, what we call a non-steroidal anti-inflammatory. That's more of your ibuprofen, your naproxen, your Aleve, those kinds of medications. Again, the reason we try to avoid medications, again, any medicines can have some adverse effects on you. If you take too much of the Motrin or ibuprofen or naproxen, it can cause ulcers or issues with the stomach. So again, they brought about a second type of non-steroidal called the COX-2 inhibitors, which is meloxicam or Celebrex. Again, there were some others in the family, Vioxx and Bextra, which they realized was causing some cardiovascular issues, causing swelling of the legs, some congestive heart failure. So they pulled those two off of the market. But the meloxicam and the Celebrex, they looked at those closely and did not seem to appear to be having those same kind of cardiovascular effects. So that may be easier on the stomach, may be better for you, and that's an option. The next thing is steroid injections. I know many people have heard about these. Some people think they're good, some people think they're bad. So from my standpoint, the plus with a cortisone injection is that you have significant short-term benefit. It helps with the pain initially, helps calm down the swelling and the discomfort. So what I tell my patients is that we can try that, but then we want to give you exercises to help strengthen up those muscles, help strengthen up that joint, so then hopefully this doesn't come back again. If you do too many steroid injections too quickly, it can affect the tendons and cause tendon tears, and it can cause degenerative changes in excessive use. So you have to be careful about how much steroids you give. For me, I would recommend, to the most that I like to give is 2 to 3 times a year, no more than that. And if you're diabetic, it will cause increase in the blood sugars. So we always tell patients to monitor their blood sugars closely for the first few days to make sure their blood sugars don't go too high with the steroid injection. Then we talk about the hyaluronic acid derivatives. Again, these are injections. Again, we talked about hyaluronic acid being one of the components of the cartilage. So these are hyaluronic synbase suparts. They're different injections that you can give. There's a one-time injection, there's a series of 3, there's a series of 5. So everyone has their own understanding which they think is best. For me personally, I do a series of 3, one shot once a week for 3 weeks. I like the idea of putting a little bit, it gets absorbed, putting a little bit more, it gets absorbed, put a little bit more, it gets absorbed. Haven't noticed any benefit with the 5 series, but again, some people do prefer that as well. So that is an option too. And then there's topical treatments, meaning if you don't like shots, if you're worried about taking any kind of pills, you can do some kind of cream. So there's capsaicin cream, there's Voltaren gel, there's BioFreeze. Again, the studies just show anecdotally they help some people, but again, there's no long-term studies that show that these are great. But again, if it helps with some of the pain and discomfort, it's something that can be tried. And then glucosamine sulfate, either with or without chondroitin. Again, we talked about these being parts of the cartilage. So there are pills that you can take, glucosamine with or without the chondroitin, with or without MSM. So again, all the studies show not a great result with this. Maybe a little bit of benefit with knee arthritis, but nothing else. But some people swear by it. It does seem that you have to take the medications for 2 to 3 months before you start noticing any difference. But again, my father had taken it, God rest his soul. He had taken it and he used to swear by it. So again, it's something that's all natural and that's something that can be tried. So when we failed all the non-medicine type of treatment, when we failed the medical treatment, the medications, our final option is surgery. So if we're talking about, when you're talking about any joint, not any joint, but the major joints, the hip, the knee, the shoulder, the ankle, the wrist, you can do an arthroscopy. On arthroscopy, you make a little small poke hole, you look inside of the joint with the camera, and you can see the cartilage and you can see what's going on. The picture that I showed of the knee, that was an arthroscopic picture. Someone had done an arthroscopy and taken those pictures while they were doing that. So when you do an arthroscopy, you can go inside there, any kind of wear and tear, you can debride that, meaning you go inside the little shaver and take it out. Obviously, if you have, for the knee, a meniscal tear, you can go in there and clean that up. If you have a rotator cuff tear in your shoulder, you can clean that up. That will help with some of the pain, but it won't delay the progression of the arthritis. Then there's something called an autologous cartilage transplant. Again, those are probably for the younger patients who've had trauma and who have a specific small defect of the cartilage. They can go in and take a cartilage from a different area and go ahead and fill that void or fill that gap. The next thing is an osteotomy, and again, osteotomy is where you're cutting the bone to take the pressure off of the joint. So again, when we talk about it, sometimes you'll see people who have bow legs. So again, as those are bowed, again, you can cut it up to try to straighten it up, or try to take some of the pressure off the knee. Again, then the next thing would be an arthrodesis, which is a fusion of the joint. Again, you don't want to fuse a hip or a knee, because obviously those are major joints that are going to move. But if you have smaller joints, like one of the, like a small joint in your hand or a small joint in your toe, you can fuse that. If you're talking about arthritis in the back, you've heard of people having fusions in their back, and again, that can help with some of the pain, because you're going to fuse the joint, so you're not moving that area anymore, so you're not rubbing the bone on bone. And the final thing is a total joint replacement. Again, you can replace most any joint. The hip, the knee, the shoulders, those are most common. You can do an ankle. They're doing disc replacements now. Some of the small joints in the feet and the hand, they're replacing those as well. So again, those are the final option, because once you replace something, there's no going back. You cut out all the cartilage and you're putting metal in there and plastic to work as a new joint. So that's what we have right now. So what does the future hold for us? So there is a lot of research being done right now about stem cell use. The first that they have tried is plasma-rich protein. And again, what that is you take a sample of your blood, spin that down, get the plasma from that. And again, the plasma has your growth factors, and that will stimulate tissue regeneration, and it promotes healing. So that's one thing. The other thing is you can take bone marrow, or you can take your adipose tissue, which is your fat, and you can take the good growth factors from there. So when we're kids, we don't have normal bones, we don't have normal cartilage or tendons, so we have mesenchymal cells and hematopoietic cells. And again, what those will do is those will differentiate into the different types of bone, cartilage, ligaments, tendon, things of that sort. So what we do is that we'll take the bone marrow aspirate, and we'll spin that down. So like when I do it, I'll get 60 cc's or 120 cc's of that, and spin it down to get about 7 to 10 cc's of those good mesenchymal hematopoietic cells. So right now, some of the insurance companies do approve that, some of it don't. So again, if the insurance company doesn't approve that, then it is quite costly to do these. So, but it is on the horizon. A lot of them insurance companies are realizing that this is a good option, and they're looking to go ahead and pay for that. So again, the studies show that this really is better for the younger patients who have arthritis, mild arthritis. It can help really long-term wise. For me, I've had multiple patients who I have injected into the knee. And again, like some young person in their 40s had one knee replaced. They came to me, they said they didn't want the other one replaced. So we tried this bone marrow aspiration and injected it into that knee. And again, it was able to make it much better. There was someone from the community who had played soccer all their life and had multiple surgeries on their knee. Again, I think it was late 40s, early 50s, and again, they said they didn't want any kind of knee replacement, so we injected both those knees, and alhamdulillah, they're able to get back, being active, playing a little bit of soccer. Again, I told him, don't go crazy with this, but alhamdulillah, he's able to run around a little bit with the kids and things. So he said it's much better, the movement's better, the pain is better. It's not perfect, but alhamdulillah, it is definitely much better than having the knee replaced. So again, the idea is that the stem cells will develop into cartilage cells, it'll suppress the inflammation, and it'll release cytokines to slow down the cartilage degeneration. So that was a quite, quick synopsis. Again, why do we do this? Obviously, for our family, we want to be active. We want the grandkids to be able to play with them. We want to be able to move around with them and things of that sort. So 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 again, that was just a quick overview about arthritis. From our standpoint, again, the best thing that we can do is try to keep mobile, exercise, try to lose weight. And from our standpoint, if you have any questions, you can feel free to reach out to me. Jazakallah khairan. Assalamu alaikum.
قد أفلح المؤمنون الذين هم في صلاتهم خاشعون والذين هم عن اللغو معرضون والذين هم للزكاة فاعلون والذين هم لفروجهم حافظون إلا على أزواجهم أو ما ملكت أيمانهم فإنهم غير ملومين